In the 30 years since HIV was identified, the progress made by science has been amazing and extraordinary, and its benefits have been felt far beyond those directly affected by HIV. And you know, now we are really entering in the new era of fighting HIV/AIDS. All this progress allow really to envisage now to reach the end of the epidemic. But for this, we need to continue to embrace science and innovation. And this is a critical issue to translate science into actions. That's why UNAIDS recently established a scientific expert panel which will advise UNAIDS on major new scientific progress and discoveries, as well as gaps and strategic needs in AIDS research, and on how UNAIDS can adjust its policy to address these needs and shape the AIDS response to move forward on our main goals. So I am today very delighted that Professor Karim, who was recently appointed as the chair of these expert panels, has agreed to take part in our discussions today. And let me say a couple of words about our guests. Professor Salim Abdool Karim and his spouse, Professor Quarraisha Abdool Karim. And it's a great honor and a privilege to have them today here in Moscow. Professor Salim Karim is a clinical epidemiologist who is widely recognized for his research contribution in HIV prevention and treatment. He is Professor of Clinical Epidemiology at Columbia University, Vice Chancellor in University of KwaZulu-Natal in South Africa, Director of CAPRISA, which is a Center for the AIDS Program of Research in South Africa, and the President of the South African Medical Research Councils. Dr. Abdool Karim's contribution to microbicide for HIV prevention spans 2 decades and culminated in the CAPRISA 004 tenofovir gel trial, which provided proof of concept that antiretroviral drugs can prevent sexually transmitted HIV infection in women. His clinical research on TB/HIV treatment has impacted and continues to shape the clinical management of co-infection patients, and you know how much HIV-TB co-infection is a huge problem regarding the increasing of multi-drug resistant strains of TB. And let me also introduce his spouse, Professor Quarraisha Abdool Karim, an honorary professor in public health at the Nelson Mandela School of Medicine at the university, associate professor of epidemiology at Columbia University in New York, and associate scientific director of CAPRISA. Professor Quarraisha Abdool Karim is a pioneer in HIV prevention for women and led the breakthrough of antiretroviral microbicides for HIV in serving society and particularly the women of Africa. But I will say particularly women in Africa, but it's impacting also the issue of the vulnerability of women all around the world, and especially in our region and especially in Russia. She epitomizes the momentous contribution that innovative science and medical technology can make to disease prevention and global health.
I'm delighted to have these guests here with us, and I hope this discussion will be interesting and useful for everyone present here. And now I would like to give the floor to Professor Vadim Pokrovsky, and I would like to kindly ask him to moderate this meeting. Indeed, 30 years we have been facing with the HIV epidemic. We have accomplished some tremendous progress in HIV treatment. However, new cases emerge, and we witness them now and again. The epidemic is still spreading, even in Europe, where it looks like they're taking the most effective measures possible. Nevertheless, the new cases are still abundant. A new infection span, let alone Russia, where the Russian Agency for Statistics has indicated that this year alone we'll already have 30,000 new infections in Russia alone, which means that the epidemic indeed is ongoing, and it will continue developing as long as new cases emerge. That's why the development of prevention measures remains a very topical, relevant issue for us today. So what can we do in order to find an approach that would that would stop the spread of HIV? I mean, we know there are zillions of approaches, but none of them has proven effective enough. So it really looks like the world is in need of new and newer prevention methodologies, and I believe their joint use is absolutely critical. I mean, I don't think we can
quickly over the next 20 to 25 minutes is I want to share with you a history of tuberculosis and HIV research that Quarraisha and I have undertaken with our research team in South Africa over the last 15 years or so. And we're really going to focus on the big challenge of integrating TB and HIV treatment, the opportunities and the challenges. So Quarraisha has already shown you this diagram and has already given you a perspective of the, next slide, of the extent of the HIV epidemic in Southern Africa. We know now within South Africa that we have about, next slide, we have about 6 million people living with HIV in our country. We have already put 2 million of those 6 million people onto antiretroviral treatment. We have the biggest antiretroviral treatment program in the world. And one of the things we have identified is that most of the patients who have HIV infection, because they have an infection that is a silent disease, they present to the health service for the first time, often with tuberculosis. So tuberculosis is a major entry point for AIDS patients in Southern Africa into the healthcare system. So when we are facing a situation where a patient walks in with tuberculosis and we do an HIV test and we identify them as having HIV infection, we are now starting to grapple with how do you treat them. Next slide. So if you look at overall the HIV epidemic, sorry, go back one slide. If you look at overall the HIV epidemic and the tuberculosis epidemics, what you see in Southern Africa is this very dark blue area. And that dark blue area indicates the very high prevalence of HIV infection in tuberculosis patients. If you look at Russia, you see a lighter shade of blue, where you have a much lower prevalence of HIV infection amongst your TB patients. But you can see you are not the lightest shade of blue. So you do have a problem of tuberculosis and HIV continuing to occur in Russia, as we have in many other parts of the world. Next slide. So in South Africa, we monitor the HIV epidemic in pregnant women every year. And this diagram shows you the way in which the HIV epidemic spread in South Africa. And you see how when HIV was first entering into the country in the early 1990s, how it spread very rapidly, and how over the last few years we've reached a stage where the HIV prevalence rate is now stable. I should explain that stable HIV prevalence means that the number of new infections that are occurring is roughly equal to the number of deaths that are occurring from HIV. So it's when the deaths and the new infections balance themselves out, you get that straight line at the top. And we know that if you look at the situation in 2008, for example, that we had in South Africa about 7,000 new infections every day. So it gives you some idea of the extent of the mortality we've had to deal with in HIV. Next slide. Now superimpose that with tuberculosis. You get to see what the tuberculosis epidemic was doing in South Africa at the same time. The red line shows you the tuberculosis notification rate. So South Africa, in the early 1990s, was actually starting to win the battle against tuberculosis. At this point here, we were achieving a state where tuberculosis was slowly going down. But the HIV epidemic changed that. It turned it around. And what you see after the mid-1990s, the steady increase in the number of tuberculosis cases we began to see in South Africa. To the state now where South Africa is one of the biggest tuberculosis epidemic, which is accompanied by the additional problems of both drug-resistant TB, and now we even have extremely drug-resistant TB. So how do we treat these patients? Next slide. We have to figure out what are we going to do if we're going to treat these patients with tuberculosis and HIV. And so we walked around, and this was after the AIDS conference that we hosted in Durban in 2000. We started talking to some of our colleagues and asked them, how do you treat patients who have both tuberculosis and HIV? What's the strategy you take, and what's the science behind it? And what we began to see very quickly was that there was no evidence. That if you asked 5 different doctors how to treat patients with TB and HIV, you get 5 completely different answers. And the reason for that, there was no evidence on which to base it. So we began to understand what the nature of this problem was. And essentially what we began to understand was that it's a balancing act. It's like a seesaw. On the one hand, you want to start antiretrovirals as early as possible because you want to slow down the number of deaths and you want to decrease the morbidity that's associated with HIV. And so on this side, you have the burden of the deaths and the morbidity from HIV that you want to slow down. And in slowing it down, you want to initiate your antiretrovirals as soon as possible. On this side, however, if you start your antiretrovirals too early, you have these 4 problems to deal with. The first is immune reconstitution, inflammatory syndrome. So what we see in iris is a major challenge that we have to grapple with. When we put patients who just have TB, no HIV, when we put them on TB treatment, we see iris quite often. If we have HIV patients who don't have TB and we put them onto antiretrovirals, we see a few cases of iris. When we do the two together, we see a substantial immune reconstitution effect. For those of you who are not familiar with iris, what happens is that when a patient has tuberculosis, their immune system is suppressed. When you put them onto treatment, and when you put them on antiretrovirals and TB treatment, what you do is you allow the immune system to recover. When the immune system recovers, it wakes up and it says, hello, there's a whole lot of mycobacteria here, I better respond to them. And so it responds, and when it does so, you have this paradoxically adverse reaction where you respond very badly, and these patients get quite severely ill. So we have to deal with this problem of iris, and how do we minimize the impact of iris? We have the problem of the drug interactions. If you put patients on rifampicin and on an NNRTI like efavirenz or nevirapine, you have this cytochrome P450 pathway co-interaction that you have to deal with. And then we have to deal with the additive toxicity. TB drugs themselves are toxic to the liver. You add now antiretrovirals and you're having all this additive toxicity. You must think about it. You've got 4 TB drugs, 3 antiretroviral drugs. You put all of that together, the patient is taking 7 drugs a day. That's a lot of medication with a lot of side effects. And then you've got the whole issue of tolerability. The worst thing to do is to put a patient on antiretroviral treatment and they stop taking their TB treatment, because TB is what's going to kill them. So we have to ensure that they take their TB medication. We can't afford to have a situation where patients will stop taking TB treatment. So we have benefits, we have risks, and how do you weigh all of these up, and how do you make your decision? Well, we had no idea how to do that. So we started off by just doing a small pilot study. And we did this back in 2003. It's a very small study. We just put 20 patients who had TB and HIV. We put them onto antiretrovirals. And we wanted to see what happened. Did we kill anybody or not? And we found, no, actually we did some good. And what we found was that the integration of these two drugs was feasible. And we showed that it was good adherence, and we had a good clinical response. So based on this very small pilot study of 20 patients, we then proceeded then to doing a large randomized controlled trial called the SAPID trial, starting antiretroviral treatment at 3 points in tuberculosis, called SAPID for short. This trial, we presented the first set of results in 2009, and the paper was published in the New England Journal of Medicine. And essentially what it shows, if you look at this diagram, that the deaths that were occurring in patients with integrated treatment, that means patients who had both the HIV and TB treatment, what you had is this picture of mortality. Compare that to the patients who were first taking their tuberculosis treatment and then taking the antiretrovirals. So if you first took TB treatment and at the end of your TB treatment started your antiretroviral treatment, you were simply waiting too long. And as a result, patients are going to die. And if you look at what impact the early initiation or the integration of TB and antiretroviral treatment is, that essentially we saw a hazard ratio of 0.44. In other words, we saw a 56% lower mortality if you initiated antiretroviral drugs with the tuberculosis treatment. You didn't wait until they first finished tuberculosis, which in fact, when we did the study, was the most common thing that doctors did. Doctors first treated the TB, made sure the TB treatment was completed, then they started antiretroviral. So we showed that that's actually the wrong thing to do, and that you could more than halve the deaths if you integrated these two treatments. So the next question was, when do you start antiretrovirals in patients who have tuberculosis? At what point in the tuberculosis should you start? Should you start right at the beginning? Should you start somewhere in the middle? Should you go towards the end? And so we began to address that question. We wanted to get some idea of to what extent we could show that we could do, at what point during the tuberculosis treatment could we initiate their treatment. Before I come to that, I want to show you a subset of the SAPID trial. That's next data. A subset of the SAPID trial is the trial we did within this population of patients who had multi-drug resistant tuberculosis. So these are patients who have resistance to at least rifampicin and INH. And in this trial, in this subset of the SAPID trial, what we show is that even in patients with MDR-TB, early initiation of antiretrovirals is protective. And we show this drastic reduction in mortality from antiretrovirals. So these are patients with MDR-TB. We don't know they have MDR-TB because the results take so long for us to get it. So what happens is that we have a situation where these patients who have MDR-TB, but we don't know that they have MDR-TB, while we're waiting for their results, if you withhold the antiretroviral drugs, they have a much higher likelihood of dying. So for these patients with MDR-TB, they have an even greater benefit from early initiation of antiretroviral treatment. Next slide. So what we've seen across the board in these three papers that were published in the New England Journal of Medicine in the same issue were a set of results that began to answer that key question. That once we showed that integration was critical, was when during integration, when during TB treatment should you initiate these patients. And all three trials basically show similar results. And I want to try and present to you in as much as a sort of simple way as I can, the synopsis of the outcomes of these three trials. And I'll focus now on the SAPID trial because the other trials concur with these. So what we showed is that if you integrate the treatment very early as opposed to late during tuberculosis, then what we find is that event rates are fairly similar. There's no drastic difference as to whether you start very early or very late. However, when you look at CD4 counts, it makes a big difference. So when we look at patients who have a high CD4 count above 50, not high, let's just say above 50, patients who are not severely immunocompromised, there is very little difference. Next slide. If you look at this diagram and look at late antiretroviral treatment and early antiretroviral treatment, if you look at those two Kaplan-Meier graphs, if you look at the way in which the mortality is occurring, you can see there's not much difference. So these are in patients who do not have severe immune compromised state. Next slide. If you look at this group, however, in patients with severe immunocompromised states, there's a drastic difference. So patients with very severe immunocompromised states, you should start antiretrovirals as early as possible. And what we want to do in this population is we want to save these lives. And you take the risk of IRIS and you take the risk of the tolerability of the drugs at this point. So what did all of these three trials confirm? The earlier you start, the better. In patients who are not severely immunocompromised, you can wait until the first 2 to 3 months before you start your antiretrovirals. But if a patient is severely immunocompromised, as quickly as you can, start the antiretrovirals. So that's the sum total of what all of these three trials. And WHO has followed this balancing act and tried to provide a simple guideline. And the simple guideline is you should integrate patients who have TB and HIV by just starting the drugs as early as possible in all of these patients. And so this balancing act between mortality and all of these potential harmful effects plays themselves out so that the benefits of improved survival are more important. So if we look at IRIS, what did we show in the SAPA trial about IRIS? What we showed is that the impact of IRIS is felt most severely in patients who have integrated treatment. So, next slide. So if we look at this Kaplan-Meier, what we see here in the early integrated group, and that's the group right at the top, they have the highest number of IRIS cases. So you have to accept that if you're going to initiate patients on antiretroviral treatment early, you're going to have to deal with this rapid increase in IRIS. And you can see that it goes up to about 20%. It's 1 out of 5 patients are going to develop immune reconstitution illness. We can control this. As you know now, with the use of prednisone, with the careful provision of care, you can actually control most of the effects of IRIS. So our IRIS is not as deadly as it used to be in the old days. In our hands, certainly, we have very few patients, if any, dying from IRIS. We're able to care for them and bring them through. The second is the issue of TB and HIV drug interactions. And here we've shown within the SAPA trial that you have this challenge of the efavirenz on the one hand and the rifampicin on the other. And when you put patients on both treatments, you have the problem of would you have an adequate level of efavirenz? And what we found is that there's not a simple answer to that question. It fundamentally depends on whether you're a fast or slow metabolizer. And what we show is that patients who are taking both forms of treatment, that overall the amount of efavirenz that they have is lower than we would like to see. And so there's some discussion now about whether we should increase the efavirenz levels. The problem with doing that is patients then get nightmares, they get the drowsiness, and so it's a problem to increase the dose. Right now, the recommendation is for us to stay with the current dose until we have a better idea of how to identify the fast metabolizers and put only those patients on the higher levels of efavirenz. So the current guidelines are to continue with the current dosages of efavirenz in the presence of rifampicin. In terms of drug tolerability, next slide, what we show is that whether you're dealing with severely immunocompromised or patients with CD4 counts above 50, we have similar levels of drug tolerability and treatment outcomes, whether it's from in terms of the HIV treatment outcomes. This is the percentage of patients who have suppressed viral load. Next slide. If we look at TB treatment completion, similarly, we see pretty high rates of TB treatment completion regardless of CD4 count in both groups. Next slide. And if we look at additive toxicities, and if you look at treatment switches, what we find is that those who start antiretrovirals very early, they have substantially more switching from their standard first line than patients who start later. So it is true that when you face the situation of all of these four challenges in terms of what is good and what is bad, it's quite a complex decision to make about whether to start early in terms of you have to accept that you will see more iris, you will see more drug switches, but you will see equivalence in terms of HIV and TB outcomes. Next slide. So what our data show is that when you have severely immunocompromised patients, you simply should not hesitate. Regardless of the challenges you will deal with in terms of drug interactions, iris, you should start antiretrovirals as quickly as possible in TB patients. However, when patients are not very severely immunocompromised, the CD4 count is above 50, you have more leeway, and you have a situation where you can start the antiretrovirals anytime within the first 2 months or so, up to 3 months of TB treatment. And you would decrease the risk of iris, you would decrease the drug toxicities, and you have a much better profile in these patients in terms of the side effects they have to deal with. So that's giving you a sense of the balance of the risks and the benefits in how and when to start antiretrovirals in TB patients. So we've then proceeded. So how do we actually do this in the real world, especially in our situation where we see, something like 300,000 to 400,000 new TB cases a year? How do you actually manage that in a real world setting? Well, the first thing you have to do is you have to make sure every TB patient has an HIV test. I can tell you that that's easier said than done because of the nature of the illness that these patients are quite sick, and the clinics and the hospitals where they're being managed is focusing on the TB. So what we've shown is that there's actually a very simple way of doing this. We simply do the HIV test on the sputum where we diagnose the TB. So when we send the result back, we tell the doctor straight away, this is a TB patient who has HIV, or this is a TB patient that does not have HIV. So the doctor knows it up front about what the course of action would be. And this gives you some data of what we've shown in our setting of smear positive patients, of just doing this kind of routine HIV testing in the saliva. But we found many challenges to integrating TB and HIV care, and we've documented it in a range of different papers over the last several years. It's a big challenge for patients. How do they getting a TB diagnosis is bad enough, and then being told you also have HIV, has this sort of huge impact on these individuals. And what does it mean for them? How are they able to cope with all of this? How do we understand their readiness to take all these drugs all at once? And how does it impact when they disclose or don't disclose their HIV status? So we have to deal with all of these challenges as we integrate TB and HIV treatment. When we released our results in 2009 from the SAPIT trial, the WHO released within 2 months or so this rapid advice. As you know, WHO releases rapid advice when there's no data and suddenly new data become available that can influence clinical guidance. And this rapid advice is pretty much based almost entirely on our SAPIT trial results on the integration of TB and HIV treatment. And that now is standard practice all over the world. So even if you look at the US government guidelines, the DHHS guidelines, they also recommend the early integration of antiretrovirals in TB patients and essentially quote much of the data we provided from our early 2009 data. Within South Africa, of course, our government has taken this up. On World AIDS Day in 2009, our president announced that TB and AIDS will now be treated under one roof. And when he made this announcement, he had no idea how difficult this was going to be to actually do it in the real world. And my colleagues here can attest to the challenges of trying to treat these patients with both diseases at the same time. But we continue to attempt to do that. Next slide. So I want to just end off by saying that TB and HIV co-treatment is a major opportunity to save lives. And that as we try to do that, and as we try to deal with the challenges, we will learn how best to do it. And the only way to learn how best to do it is to actually do it. And it's in pretty much the same case of much of what we've learned. You actually have to do something and then understand its problems and fix them and try and do better as you go along. I want to acknowledge the patients in our studies, the SAPID study and the range of different studies we've undertaken on TB and HIV, PEPFAR that provide a lot of the infrastructure for us to care for our patients, the Global Fund, the city, the province where we come from, and the NIH that enabled us to undertake these studies. Thank you very much for listening.